Buenos dias. I'd like to start by thanking you for inviting me over here to talk to you about my experience in Kent. I'd like to start by just explaining. Sorry, is it working? Is that good? Okay, fabulous. Kent is a large county, so in the southeast of England, going from London all the way down to the coast, and that whole corner in the of England. And I, as I say, am a health visitor team coordinator, so I manage the health visitors within my district. Within Kent, there are 12 districts, and within my district, there are about 8 or 9 towns. So just to give you an idea of the sort of the area I cover. I'm going to start by going through just my qualifications, because I thought it'd be useful to have a bit of lap over from Angela's talk this morning about specialists, nurses and advanced practice. So my title is Specialist Community Public Health Nurse. To the public, a more familiar term for my job and role would be a health visitor. As a health visitor, I am involved. We monitor all children under the age of 5. We monitor their growth, their development. We assess parenting. We assess attachment. We are nurse prescribers, and in order to become a health visitor, you need to be a general nurse, and then a lot of us have done specialist nursing. My background was in critical care, where I did my university training to become a specialist nurse, and as part of our training to become health visitors, and with regard to the advanced practice, we obviously go back to university. Some examples of the advanced practices we do are obviously writing legal reports if there's any sort of like law proceedings where there's concerns regarding children, vulnerable children, the level of parenting they're receiving, and whether we need to remove them from their parents. My other qualification is a community practitioner nurse prescriber. That means I will go through the levels of prescribing currently in England a little later, but essentially you need to be an advanced nurse to do the first level of prescribing, and as I say, I'll go through that a little bit later. So obviously leading on from Inuba, she's gone through the role of the walk-in centre. I'm going to sort of expand on that because we have lots of different types of walk-in centres and clinics available to the population of all ages within the UK. The one that I'm particularly involved in is Healthy Children. So the clinics that we deliver as health visitors are for children and families and anything that may arise within those. I will discuss the training requirements, sort of moving on again from Inuba of walk-in centres and walk-in clinics and what training is required within the other clinics, and as I say, carry on with the nurse prescribing and the benefits that clients receive from this. So we've heard about walk-in clinics, minor injury units. We also have in England sexual health clinics. Again, these are nurse-led, nurse-run. They can offer emergency contraception. And advice about sexually transmitted diseases and treatment. We have nurse prescribers in there treating direct, which for the patient obviously is beneficial. It means that they can go there after work, get their treatment. It's sort of a one-stop shop. We have other clinics that support the population around domestic abuse. Again, these are run by health visitors with other partners, say police or whatever, depending on the area. I will talk later, obviously, further about our healthy child clinics, but we had a nice overview by Inuba about obviously how it improves client access, that the whole service is more responsive as far as for busy people, busy lives. They can have the consultation with the nurse, with the health visitor, and with the minimal disruption to their life. And it also offers more choice. It's faster for people if they need referrals on. It sort of cuts out the GP, sort of the middleman. Years gone by we would have to refer to the GP, then and explain why, and then the GP would then have to refer on. We've cut the GP out, so we refer now direct for any matter of issue that affects families and our population. So I know I've started telling you about the role of the health visitor. Obviously we're here as a health promotion role, avoiding illness, staying healthy. We're part of the team that offers screening and development. Any children, we do specialised examinations where we will aid children's development for every area, from locomotion to speech and language to everything, and refer them direct to teams that can then support the family. We obviously copy the GP in so that they're aware, but ultimately they just come to us and we deal with it and it goes on. In the UK, the role of the health visitor that I do has been obviously recognised, and there's been a health visitor implementation plan which set out like a call to action to expand and strengthen health visiting services. And this is where we are currently. By 2015, across the UK, our challenge was to increase the number of health visitors by 4,200, which in the grand scheme of things, UK is a big place, doesn't sound like a lot. But for us in Kent, we have had to expand our workforce of advanced practitioners, the health visitors, by more than 50% in the space of about 3 or 4 years. A huge challenge, and we're just coming to the end of it. Health visitors obviously have been recognised, and that's why they're doing this, that we are ideally placed for the early recognition of any issues that can develop into problems further, or risk to the family that if not addressed. They believe that obviously the sooner we can get in, whether that's a nurse running a walking centre, or a health visitor working in the community with families, the sooner we can get in, the sooner we can identify the problem and refer it to the correct place, the better. Inuba's obviously touched on the fact that we have there are problems for people to go and see their general practitioner, their GP, and I would obviously, yes, I agree, people do, they will come to walk-in centres and then they'll go to their GP to let them know that they're better and what's happened, which is quite frustrating, because at the end in my references there's reference to somewhere a department from the UK called Monitor, and they've just done a survey on the effect of walk-in centres and why they're closing. So with anything, with change, we don't like change as nurses, and likewise I think we all need time to change, and likewise the population needs time to change, to realise and to have faith in these new ways of working. So that we can take them forward, and it's that we just need to keep them and make sure we carry on promoting what we're doing, so that the true value is appreciated. So we hope, as health visitors, we obviously also search for local health needs. We, like within walk-in centres, we have like auxiliaries, they're nursery nurse trained. We have qualified nurses, so like general nurses, and then we have the nurses that have gone on then to become health visitors, so like advanced practitioners. There we go. I've got a few things here. So the aims of ours, so I'm going to move now specifically onto the clinics we run as health visitors. We do a lot of the growing and measuring and assessing of development within children, again with the aim to pick up any problems with growth, and direct people with any problems, speech and language, for children, so that by the time they get to school, everything is in place, the child's supported to hopefully then continue within the normal schooling route. In order for us to do child health clinics and for our practice, in the UK, all our practice is underpinned with protocols and guidelines. So we have guidelines for clinics. So all members of staff, whether you're the auxiliary, whether you're the specialist health visitor, will follow a set of guidelines on what should be provided within that clinic. We have national NICE guidelines, which are national guidelines for clinical excellence. And again, that's to ensure that the advice they're given at one clinic to the next, is exactly the same across the whole of the UK. With guidelines, within Kent, where I work and I've been involved with, it's a big county. It was divided into two. But we've come together, again, cost savings. They've reduced the management. So instead of 2 managers, 2 deputy managers, we have 1 across the whole larger area. And ultimately, we've had to come together with our guidelines. So we're having to now write across. And probably like the different islands here, there's different practices. Obviously, we've heard in Andalusia and here are obviously different. And things are moving at different paces. So where we are in Kent, we are trying to pull ourselves together so that we are all offering exactly the same. If you were to go to a clinic near London in Kent, you would get the same service, have the same services offered, and would be treated the same as if you were to go to the coast where I work. We've talked about venues and timings, what Anuba has as far as the extended role. With the healthy child clinics, they tend to, at the moment, only run 9 till 5, Monday to Friday. But that, again, is part of our new moving forward plan within the UK. We are soon to be offering a service 8 till 8 and to include the weekends. Trained staff, I'm not going to go back over what Anuba said. Essentially, it's the same auxiliaries, qualified general nurses, and then your specialists or advanced practitioners. There's lots of possibilities for the future. Another reference I've got is obviously the Wirral Clinic. It's on my... If I don't know if you can get it translated, but it talks about the future of the child health clinics, how we can move them forward, and as far as to encourage more engagement with the population. We've found with child health clinics and with nurse-led clinics that the population do prefer it. There's sort of the feedback we get. They do prefer it because of the they get more time with the general practitioner. It's a 10-minute slot, and before they know it, they're in, they're out, and they've got a question. So the clinics enable families and members of the population that time to talk to a nurse about what's going on for them, because sometimes I think the GP model is very medical, whereas certainly within the community, and I think in the walk-in centres, we're sort of medical and social model. So we're looking beyond, possibly sometimes always the medical condition, to see what's brought someone in. So I'm going to go on. Where am I? To nurse prescribing, just to try and explain to you. I know Paco explained the 2 levels here at the moment. So what is the pointer? I'm a level 3 nurse prescriber, and basically all health visitors will come out. It's part of the specialist training. You have to be a nurse prescriber. I can prescribe, I don't need a doctor, but I'm limited on what I can prescribe. Limited to mainly creams, antifungal sort of treatments, dressings, paracetamol, Piriton, sort of antihistamines. So not a huge amount of scope. And a couple of years ago, within Kent, we had a look at what prescribing practice was like for health visitors. And there wasn't an awful lot, because there's not an awful lot in our, what we call a formulary, in the book of the medicines that we are allowed to prescribe that people can't buy over the counter at their pharmacy. So the plan is for my profession, health visiting, is for us to move up to where are we? Into the type 2, where you'd have the whole formulary of medicines and you can prescribe yourself. So you do the assessment, your diagnosis, and you prescribe, and then you review everything yourself, and that is the way, and that is what I will be, and all my colleagues will be, obviously moving to and going through university to take on this extra qualification. The other one that exists, which Paco did speak about, is the one where there's like a mutual agreement between a nurse and a doctor, and that's the type 1 on my slide here. This works across the NHS in a variety of settings already. We have something people call district nurses, so I would say they're specialist nurses that work in the community and go out to see patients with dressings and wounds or catheters, and basically by sort of a pre-arranged agreement and with we call them patient group directives, so with a set protocol. So if the patient meets these, sort of hits any of these sort of targets, these things are happening for that patient, then that nurse, it's already been agreed, it's already set down, can prescribe that medication. But obviously you're restricted with that one. A good friend of mine who is a matron in the community is, again, because the move, like here, is for more autonomy of nurses, and she is currently doing the independent prescribing, which is the second one, which I think this one I think is going to stop, because there's little value, unfortunately, because we're so limited on what we can prescribe, even though we can do it on our own without a doctor. The ones that seem to work the best in England are the ones where there's a partnership with the doctor, with the GP, on what to prescribe in which circumstances, and then obviously the independent prescribing. So, what are the benefits of healthy child clinics or any clinics? Obviously, it's the prevention and early intervention. Whether you're going into a walk-in centre, whether you're going into a sexual health centre, whether you're seeing the health visitors at the children's centres, essentially you're getting that early intervention, point of access. You're not then having to be referred on to anyone else. So it's nice and timely. Obviously, although we don't have to pass things on to the GP, obviously we work closely with them, and obviously that helps us to improve and enhance our skills, and sort of like regain that autonomy. It makes, as far as for a career, it's very desirable. As I say, with the numbers we've had to increase, there's been a huge amount of people applying. It's a very difficult course at university, and it's very academic. But ultimately, I think people can see nurses are empowered to think, goodness, yeah, I want to do that, because I want to be able to go there, make a difference, and stand on my own and prescribe and do all these things. And it works together well. The GPs see our role as very autonomous. At the moment, the most amount of autonomy I have within health visiting is around safeguarding, protecting children. We are the voice, as I said earlier. If there's any investigations and it's going to court, legal proceedings, it is us they come to. We write the report. It's our opinion on that parent's ability to parent those children, or that parent's impact, whether the impact of their parenting has had on those children. Does it warrant them to be removed and to be cared for by someone else? For us, also, the Healthy Child Clinic, it's sustainable. As long as we've got a venue, we've got our qualifications, we've got our support staff. As far as we're not reliant on any additional funding, and obviously we're continually kept up to date with all the skills we need to implement our way of working. I'd just like to add, it's not on my slide, because I think the next bit's any questions, just about emergency nurse practitioner. Inuba was talking about, obviously, the problems and the fact that we haven't seen a great effect. The effect of the walk-in centres hasn't been seen sort of financially yet, or by the GPs or by the A&E departments, and for reasons of, obviously, it's that whole change, and that people are going to A&E still for a second opinion, or they're going back to the GP just to report back to say that they're well. So we are looking in the UK of how we can change that, how we can support the continuation of nurses and nurses leading clinics, but at the same time, bring the population along with us. And my husband is an emergency nurse practitioner, and where he now works, he used to work in a walk-in centre. He now works in a GP practice, so they're under the same roof. And they do not get this. They don't get people going to see my husband at the nurse to be treated, and then wanting to see the GP, because for the patient and the population, they're going to the GPs, and they actually, it's wrong, and they always get corrected, but they actually refer to my husband as a doctor, even though he isn't, because they feel they're getting a doctor, assessment by a nurse. So again, it's something we need to work on, because obviously my husband will never profess to be being a doctor, but I suppose the lines of our profession are beginning to blur for populations, because they'll go and see a nurse now, either at a walking centre or, in my husband's case, at a GP, and the client now thinks they've seen a GP just from the way they've been assessed and the training we've had to assess medically and move things forward and refer on, and the fact that we've got that, we can refer direct. We do not have to ask permission from the GP. We refer direct into hospital to consultants for different areas. So yes. Has anyone got any questions? I know we're going to have the debate in a moment, but I will just bring up some of the references. The bottom one, Monitor, I know it's all in English, is just from this February, and that's the final report in the UK about walk-in centres reviews and the recommendations. So it's sort of very, very, very new, and it certainly might be worth looking at if that's something, so you can learn from, obviously, from our experience, and hopefully, when you move into sort of having nurses being more autonomous and running things like this, that you can learn about how perhaps we didn't promote it well enough, we didn't get our population on board and reassured that they didn't then need a second opinion from anyone. Is that okay?